Yes, ma'am.
Everybody can see? Okay, I'm gonna start my my PowerPoint then. Okay, what about now? We good?
Yes, we can see it.
Okay, all right, so let's get started. So we're gonna dive in. We're talking about the concept of tissue integrity, and we all know when we're dealing with tissue integrity, it's just mainly talking about the skin, the breaking of the skin, and skin serves as our what? Our protection, right? So anytime we start, and I want y'all to talk to me the same as if we were in class. So when we talk about skin, our skin serves as our protection, and if it breaks, if there's any kind of breaking the skin, then what is allowed to get in the skin? What's allowed to get in the system?
Bacteria.
Bacteria, germs, all that kind of good stuff is able to get in there, okay? So there are 4 types of tissue that we'll be talking about just a little bit. That's gonna be muscle, any kind of neural, any kind of connective tissue, and also epithelial. So did we all get a chance to do our reading? Did we all get a chance to do our reading?
No.
Okay, so just make sure y'all touch on that, okay? So if we were to define our concept, that would just be the state of any kind of structurally intact or physiological function of the epithelial tissue. And we just mentioned that, such as any kind of intimate or mucous membrane. So if you have any break in any of those things, you can kind of cause a problem with bacteria and all that kind of stuff getting inside the body. Because even though all of us carry staph on our skin, we don't want staph to get inside, okay? Everybody with me?
Yes, ma'am.
Okay. So it serves as our protection. We have 2 layers that we're going to focus on. That's going to be the epidermis and also the dermis. So if we always try to cover the stages of life. So if we look at infants, and we all know the infants have a thinner skin, it's more permeable, it's easier to break. And what else can you all tell me about infant skin? It does what? It's easy to do what? If you keep wetting
stretches.
It'll dry out. So have you noticed that anytime you have a baby and you notice sometimes the baby's skin will break, it's probably because it's drying out. So we always want to make sure we keep their skin nice and moist, right? That has less subcutaneous fat. And so with adolescents, what is one thing that adolescents are prone to?
Acne.
Their skin, acne. So they have an increase in the apricot sweat glands, and that's why we always try to tell them to wash your face, keep your hands out of your face, because you can introduce bacteria into that area, okay? So they have an increase in their sebaceous glands, which is that oily gland, and that's what gives them the oily skin. So we always want to try to make sure we tell them to wash your face twice a day. And a lot of times at this point, they're always going to, sometimes the patients will go to the dermatologist, and the dermatologist may prescribe them something like some benzoyl peroxide or something like that, which will dry the skin out. It'll help with drying it up so that you won't have as much oil. Does that make sense? And then we have our older adults, and we already know that their skin is thinner, and they have a decreased perception. So what do we mean when I say decreased perception, Caitlin Connor?
Like, can I guess? Because it may be wrong.
Well, guess. Let's see. We'll correct you if you're wrong.
Like maybe they can't like perceive like hot or cold temperatures as well as we can.
That's actually correct, Kayla.
Oh yeah.
That's right. Okay. So we have 6 major categories that we want to look at. We look at trauma and injury, any kind of loss of perfusion. And what is loss of perfusion, Brittany Morgan?
That's when the fluid is not circulating through the body or getting to certain areas of the tissue.
Right, the blood is not circulating. So what happens when you don't get good blood circulation, Cody?
Tissue breakdown?
Yeah, tissue breakdown. You can have tissue death, necrosis of the skin. You have immunologic reaction, any type of infections. And what about infestations, Sarah? Sarah Smith.
Infestations of like bacteria.
What about where you have the burring of the skin from different kind of little mites and stuff like that go under your skin?
Okay.
Mm-hmm. And then you have thermal or any kind of radiation injury, and then any type of lesions. And we'll talk about lesions a little bit more as we get through the lecture. Everybody with me?
Yes.
Anybody got any questions? Okay. All right, so consequences. You have your thermal regulation, you got your elimination, and these are some of the things that can cause you to have skin breakdown. Fluid and electrolyte balance, protection from any kind of infection, safety, comfort and pain, or body image. So if we're looking at any kind of age-related risk, if you notice that a lot of times when I was in practice, I would see this all the time where moms will bring their babies in, and a lot of times the baby may have a diaper rash. So who can tell me what may cause a diaper rash?
Leaving them in a wet diaper for too long.
Right, leaving them in a wet diaper for too long. And so I would talk to some of the moms sometimes, just kind of ask them what happened. And a lot of times they would try to make, they would say they wouldn't have a lot of money, so they would try to make the diapers last, so they would leave it on the child a little longer than they should have, and that would cause the child to have a diaper rash. So any kind of uncertain mobilization, what we mean by that is if you're not able to move around as much as you possibly would, you could cause yourself to have breakdown, or the patient could have breakdown because we're not turning them. So that's why it's so important that we make sure we turn the patients every 2 hours or as needed, because sometimes it may not be 2 hours. We may have to change the position before 2 hours. And there's nothing wrong with that. You're just trying to make sure that you protect the patient from any kind of exposure or any prolonged exposure with bony prominence, especially if you have your small patients, your tiny patients that don't have a lot of fat pads. Inability to protect themselves from any kind of environmental dangers. What I mean by that is, let's just say you have somebody that's laying on a hard surface, or you have somebody that may be exposed to prolonged heat or cold or anything like that. Those things can also cause you to have breakdown. So that's with the infant population, because they're not able to move as much. But then when we get to the school age, we're worrying about them jumping off things, falling, right? They're just not learning how to ride a bike. They'll fall off, skin their knees up. They may fall and hit their head, and that's why we stress the importance of wearing helmets and things like that, because they just are prone to accidents at that age. And then with older adults, our concern is skin tears. Jesse Cooper, tell me, why is our concern skin tears on older adults?
Because their skin is thinner and they're more prone to like if they, like, say if we hit something, it's probably not going to be that big of a deal, but to someone older, since their skin is thin, if they hit something, they could, like, their skin could tear. And
that's right. So did a lot of you see, and I know at the LTAC that we were in, my group, did a lot of you all see skin tears where they had dressings and things on the elderly patients that you were taking care of?
yeah.
Y'all can talk.
Yes, ma'am.
Okay, what happened? Let's see, y'all. Hold on, y'all. I'm trying to make sure I see what happened to my PowerPoint. It doesn't look like it wants to. There it is. Okay. So any kind of health conditions the person may have. Now, this is going to be super important, so I want y'all to pay attention to this, and I want you to kind of get involved. I really can't see exactly now that I'm sharing my screen with who's on here. So let's see if I can show. Okay, so I got a small little thing I can scroll through. Okay, so when we talk about any kind of individual risk, what I'm talking about are any kind of risk that will put the person to, that would increase the person's risk for having skin breakdown. Okay, so we'll talk about health conditions. Let's see, Brandy Murphy, can you tell me some health conditions that may cause a person to be at risk for skin breakdown? Brandy Murphy.
Would it be
Right.
eczema or something like the other sort?
Eczema is a part of the skin condition, but I'm saying any kind of underlying health conditions that they may have.
Diabetes.
Diabetes is good. What about you, Aaliyah? Do you have one? Well, Sharon, you raise your hand. You want to ask me a question, Sharon?
Yes, ma'am. I was going to say lack of nutrition.
Lack of nutrition is a good one. Diabetes is a good one. Who else can name one for me?
Smoking.
Ma'am? Who is that talking?
I just said incontinence.
Incontinence, but I'm talking about any kind of underlying health conditions.
What about
We're talking about
COPD.
Obesity could be one. Diabetes, and why is diabetes one? Because of the perfusion, right?
Mm-hmm.
So if
Yeah.
a person is overweight, and let's just say that they have abdominal folds there, what do we need to make sure we do to those abdominal folds?
Lift them up.
Lift them up and do what?
Clean it.
Clean it. What are you gonna clean it with?
Huh?
What are you gonna clean it with?
Chlorhex. I don't know.
Who is that, Kirby?
Yes, ma'am.
Kirby, what you gonna clean it with?
Some chlorhexidine white.
Or let me ask you this. If you were in an actual home setting, they may not have those chlorhexidine white. So you can use regular soap and water. Now let me ask you this. After you clean it with soap and water, what do you need to make sure that you do, Kirby?
Dry it off.
You need to make sure you dry it. What happens if you don't dry it off, y'all?
It can break down more.
It could break down even more. So when you get ready to go to the actual clinical setting, you'll see this. If a person has skin breakdown or they have some type of rash or whatever the case may be, they may order a cream for you to put there. So this is a question I have, Austin Walthrop. If a patient already has cream there on their surface, what do you need to do before you put new cream on them?
You want to scrape off the old cream.
You want to wipe it off. That's right. You want to make sure you wipe it off before you apply new ointment. Why wouldn't you just stack it on top of there, Austin?
It's just not doing anything. It's just sitting there.
Exactly. So any type of exposure that you may have, surgical procedures could put you at risk because not all surgical wounds heal, right? So you have some that get infected, start draining, they have to go in there and open them up or whatever the case may be. So surgical procedure can do it, genetics, skin cancer risk, or any kind of dermal ulcer risk. So the main thing we want to do as nurses is we want to make sure we do an assessment on the patient. We want to know how long has this been there. We want to make sure, they tell us what happened when it started. When did you notice it? What have you been doing to keep it clean? What have you been putting on it? Have you seen anybody for it? Have you ever had this in the past? Those are things that you're going to want to know. And then you want to actually take a look at the site, because when you go out to talk to the provider and you want to tell the provider what you see on the patient, if you can't tell them where it is or what it looks like, then that's going to be an issue. In order for you to talk about something and give an educated opinion or whatever the case may be with the patient, you need to examine it. So that means you may have to pull the clothes up, you may have to pull the sheets back, you may have to do whatever you need to do in order for you to take a look at whatever that site is, and that'll give us a better understanding of what we're dealing with. And then we'll have some diagnostic tests, and we'll talk about that in a minute. Is everybody with me?
Yes. Yes, ma'am.
Anybody have any questions so far?
No.
Okay, so you all remember back when Ms. Gordon was giving her lecture on allergens, and she was talking about patch testing. Now with patch testing, let's just say a person has allergies or whatever the case may be. A lot of times they would send them to an allergist, and the allergist may do some skin testing. Does anybody know if anybody ever had skin testing done?
I have.
my son has.
Has had it done. And so you'll notice a lot of times they'll start on the back, and they may take whatever they think that the person is allergic to. It could be dust mites, it could be grass, it could be roaches, it could be feathers, it could be dust, it could be anything. They'll take a little part of that and they'll introduce that to the person to see if they have any actual allergies with it, and they're looking for it to be applying. Now let me ask you a question. If somebody was having allergy testing done, what do you want to make sure that you have readily available? Because guess
Benadryl. Benadryl.
Some type of who said Benadryl?
Me,
That's you,
Brianna.
Brianna? Okay.
Yes.
Yeah, you want to make sure you have some kind of antihistamine or some kind of anaphylaxis, epinephrine, whatever they have. You need to make sure you have that available, because what happens if the person is actually allergic to it and you introduce it to them? What's going to happen?
They could die.
They could have an allergic reaction, and if you're not prepared, that person could very well, have some problems right there in the clinic with you. So you just always want to make sure you have your emergency equipment close to you, regardless if it's Benadryl, epinephrine, whatever the case may be. You need to have it on hand. Wound cultures. Who can tell me a little bit about wound cultures? Jennifer Haney. Jennifer.
Sorry, my internet is not doing well. What did you
Okay.
ask?
I was asking, could you tell me what wound cultures are?
Where you take like a scraping of the wound and have it tested?
Mm-hmm. But how? So let me ask you this: if you were to do a wound culture, would you start the antibiotics first before you do the wound culture?
No, ma'am. You would have to receive the culture first. That way you could determine what kind of antibiotics need to be given.
All right, now we're cooking with some grease. All right. All right, so look, y'all, when you're doing wound cultures, this is going to be important. When you're doing wound cultures, if you're trying to collect the culture off of a wound, do I want to collect the culture off of dead tissue?
No.
No.
Why not? Why not?
Because you have bacteria living on your outside of the skin already.
All right, and if you got the dead tissue there, that's not gonna help us, because it's what?
Dead.
Dead.
It's dead. Okay, so what if we have this yellowish, slimy little stuff on the wound, which what we call slough? Do we want that?
No.
Okay, why don't we want that?
Bacteria.
Okay, so what do we want then?
Is it the pus?
You want the fresh
The
air.
drainer.
We want the pink tissue, right?
Yeah.
So we want to make sure because the pink tissue has what?
Viable cells.
Yeah, and it's nice, and it lets you know that it's still alive, right? So if we were doing a tissue biopsy, we would take part of that tissue and we would send that tissue off. And then a Woods lamp is just where they take this lamp and they kind of hold it up to whatever the area is to see if it'll be able to give us a better picture of what we're dealing with. Everybody with me?
Yes, ma'am.
Okay. Is it raining where you all are? Because I think that's probably what's going on with my internet.
It's not raining here.
Okay.
It was raining in Clinton, but it stopped.
Okay, so I'm trying to move to my next slide, and it seems like it's doing something delayed.
Dr. Laws.
Uh-huh.
I've been having an issue with the PowerPoints all morning too, and I'm not sure if that's because of the weather or just because
I think it is. I really think it is, Lawson. That's why I ended up coming to the school, because I didn't want us to have this problem when I was at home. So I'm at the school trying to do this, and I'm going to see. I think that's what it is.
Dr. Loss, could you repeat the Woods lamp?
The Woods lamp is just a little device that they use. It has a light on it, and you shine it over the area that you're concerned about, and it just kind of shows you, if gives you a better view.
Thank you.
Uh-huh.
Dr. Laws,
Yes, ma'am.
will this Zoom session be posted on Canvas?
It will. Yes, ma'am.
Thank you.
You're welcome. So let's talk about, we've talked about clinical management. We're talking about our primary prevention, our secondary prevention. Primary is where we do what? And I'm trying to, let me see if I can open up my little gallery again. Brianna McNair, tell me what primary prevention is.
That's when I'm confusing the primary prevention with the primary health level.
So with
It's
primary prevention, you want to make sure you don't have a problem with it at all. You're trying to
Okay.
prevent it before it even gets started.
Gotcha.
And then with secondary prevention, you've had an issue with it, but you're trying to prevent it from getting any worse. That makes sense, y'all?
Yes, ma'am.
Yes, ma'am.
Is everybody with me? If you got a question, y'all, just don't be afraid to let me know. Let's see. I don't want to mess this up. Okay. So y'all, when we talk about screening, when we talk about skin cancer screening, this is something that we always want to make sure we pay attention to. And I know you all have heard this in the past about the A, B, C, D, E with when you're dealing with any kind of malignant melanoma. So you first want to check the symmetry of it. Check the symmetry of whether it's a mole or whether it's an area that pops up on your arm or whatever the case may be. You want to look at any kind of, you want to see is it the asymmetry is there, because it usually is not. If you got some border irregularity where half of it's raised, half of it's down, you want to look at all that. And then any kind of color variation. Is the coloring different? Is it odd? Is it like a darkish color? What it has a color changed? Is it greater than 6 millimeters? And a lot of times we'll tell we need to pay attention to this. And sometimes if you're working in dermatology, if you're going to be a nurse that works in dermatology, you may be the one doing some measuring of this. And when the measuring is done, the person may have it measured when they come in for the visit. If it's benign, or if they think it's benign, they may tell you, well, I want you to come back in 3 months. And what they'll do when they come back in 3 months is we'll check to see has it gotten any bigger. Does it look different than it looked before when you came in? And that's really what you're looking at. Because every time somebody comes in doesn't mean they necessarily have to have something removed, unless the provider thinks that there's something going on with it, that it could be cancerous. So is it evolving or changing in any type of way? Those are things that we want to make sure we look at. And so that's why it's important to ask the patient, when did you notice this? Did it look like this? Has it changed? Has it gotten bigger? Has the color changed? Have you ever had one of these before? Have you ever had to have anything like this removed? Has your family ever had to have anything like this removed? Those things are going to be important. To make it sense? Am I talking too fast, y'all?
You're good. It makes sense.
Okay. So pharmacotherapy, when we talk about our interventions, that could be whether we're using a topical ointment, a topical cream, any kind of wound care. If the wound is too bad, let's just say you get down to where you're down to the bone or whatever the case may be, or you're trying to heal up a wound, you may have wound care done every 8 hours, depending on how bad it is. They have a device now, a wound bag that you can put on that's changed 3 times a week. That'll be 9 times out of 10, Monday, Wednesday, and Friday. They'll change it out. And what it does is it helps to pull that wound closed. So if you got a wound that drains, it's going to help to pull that drainage out, and you'll see that drainage in a canister. So it's really just to protect the skin. Now, if you got somebody that has a wound bag, it's going to be super important that you make sure that this patient stays clean and dry, because any kind of moisture or stool or anything like that can cause that the dressing to that wound bag to come up. So you always want to just try to make sure you pay attention to it. If there are any kind of leaks or anything in there, that machine is going to let you know there's leaking. So just kind of pay close attention to that, okay? Phototherapy, like we said, is with the light on the area. It kind of helps to dry it out, kind of helps the area that's exposed to heal, and then any kind of surgical treatment. Now, let me say this when I'm talking about surgical treatment. When a patient has a wound, and let's just say I've seen this a lot in the paraplegic patients or patients that are paralyzed, completely paralyzed. If you have somebody that is constantly lying down and doesn't have a lot of fat pad back there or anything to cushion, and they have a wound that won't heal, sometimes they may have to do a flap, and they'll go in there and they'll actually surgically cover that area. But you also have to make sure that you pay close attention to those things as well, because if you're covering it, just make sure you know there's no muscle underneath there. So I've got some chats. Let me see. Y'all, believe it or not, I want to read the chats, but I think that it's not going to let me do all that. So did somebody say, Jesse, you asked what did I say about the woods lamb? Jesse.
Can you hear me?
Jesse, did you get an understanding about the woods lamb before?
Yeah, yes, ma'am. Sarah ended up asking you. And,
okay,
and
then, okay, because I was in the midst of everything and didn't even pay attention to the chat line. So if you got a question, y'all just say something, because like I said, I'm trying to look at this screen. So just say something, okay? I won't get offended. Is everybody with me?
Yes, ma'am.
Yes,
Okay,
ma'am.
good. So let's see if I can. Okay. So we got our impaired tissue integrity. It can occur in any individual. As we talked about, it can happen from babies, children, older adults. It doesn't matter. Okay. So any kind of nursing considerations that we may have, it could be with babies, you know, they lose heat rapidly, and that's one of the reasons why we always try to keep them covered up or whatever the case may be, because they can lose heat. They have a difficulty regulating their body temperatures. They have increased absorption of harmful chemicals. So let me talk about that for just a minute. Do y'all see that on my screen? I don't know why it's doing that. Okay, so I think it's the weather here. But when we talk about absorption of harmful chemicals, if you noticed, when a child has to get some kind of topical put on, what do they usually order the topical in? Is it a cream or ointment?
Ointment.
Who said ointment?
Sarah.
So listen, Sarah, with an ointment, and I want y'all to pay attention to this. With an ointment, you know, an ointment is more dense. It's gonna stay on the patient longer. So you notice in the very beginning, when they're smaller, they get creams a lot. And then as the child gets older, then they'll start putting ointments there. Why? Because ointments are more potent than creams are. Does that make sense? When you start thinking about your Vaselines and stuff like that, it stays on your body longer, right? Y'all can talk to me.
So like ointments would just be for diaper rashes and stuff like that.
Well, you can use creams in the beginning. Like I said, when they're smaller, they typically give them creams when they're smaller. As they get older, they'll start doing ointments.
Dr. Lott, wouldn't it also, like, I understand that it would be a cream. Wouldn't it be more sensitive? Like, it would be more softer to the skin also for a cream rather than an ointment too?
Well, the ointment is what will stick to you the longest. So the main thing about it is don't look so much about the creams and the low. Don't look so much at that. You're looking at the reason why. You're looking at the potency of the vehicle. The cream or the ointment is just a vehicle that the medicine is applied in. Does that make sense?
Yes, ma'am.
Yeah, so let's just say triamcinolone. Triamcinolone is a topical steroid. And when they're smaller, you may see them say they're putting it in a cream consistency for a child because it's not as potent as when you use it in an ointment. Does that make sense?
Gotcha. Yes, ma'am.
Huh?
So ointment is more harsh to the skin than a cream, basically.
No. Ointment is just saying that when you put an ointment on somebody, the medication in it is more potent, which means that you have more adherence or more absorption of that medication.
Okay.
That makes sense?
I have a question.
Okay.
Would you say that an ointment is more like oil-based? Is that why it sticks to the skin?
It sticks to the skin because if you think about an ointment, think of Vaseline.
Right, and if you use a lotion, like a lot of times water can rinse that off.
Can rinse it off.
Ointment is more water resistant, so it stays longer and takes longer to absorb.
And it'll make it where it'll absorb better as well.
Yes.
So you got to look at it. Children are not little adults, so we can't give them the same amount of steroids or anything like that you would give an elder person. Even if you try to put ointment on a child, it can cause discoloration of the skin. It can thin their skin out. Did y'all know that? So that's why you got to just kind of make sure when that, and you'll see providers will not as quickly give any kind of topical steroids and stuff like that when the child is smaller.
Okay, go. Never mind. Sorry.
Somebody else had a question? Is that
Yeah,
you,
I
Jesse?
did.
Okay, go ahead.
So when you're saying increased absorption of harmful chemicals or medications, whether it's ointment or whatever else, you're just saying with infants and children that we need to be mindful of how much we're giving them because
there you go. There you go, Kayla.
Okay.
Yeah, that's what I'm saying. Because they're at risk for increased absorption. So we got to make sure any kind of chemicals, and we'll talk about this when we get a little bit longer in the lecture, but that's why you got to be mindful of any kind of medications. You can't go in there and say, oh, little Billy has a rash on his arm, so let me go in there and use the same ointment that Dr. Big Jack gave me.
Right. Okay.
You understand what I'm saying? I can't use the same thing on little Billy that he gave me because guess what? Little Billy's gonna be able to absorb a lot more than medication than I could. You understand what I'm saying? Does that make sense?
Yes, ma'am.
His skin is thinner. Y'all remember, that's why you got to tie all this in. His skin is thinner, their skin is more permeable, and if you put steroids on the child like that, I just told you it can thin the skin out. So if the skin is already thin, what we doing to it? Everybody with me? Yeah, is everybody with me?
Yeah, we're with you.
Okay, if y'all got any questions, just stop me. It doesn't
I
bother
have
me.
one more question.
Okay, Jesse.
So, like Boudreaux's, that's considered. Is that considered like an ointment, like a?
That's more of a preventive measure, and the Boudreaux's is in that you using the paste or using the ointment, the Vaseline like type.
Like a paste.
Okay, and what that does is it protects any kind of the urine from getting to the skin. So that's more of a protective barrier. Now let's go back, take that question you just asked me, Jesse, and let's go back to tie it in with our clinical, our actual clinical when we were going. You had elderly patients there that they were having you put skin protective barrier on, right? Y'all remember that?
Yes, ma'am.
You had to put a barrier cream on the patient, and when you get ready to change them, they had some kind of barrier cream that you would put on, and it was a protective barrier. The person didn't have a problem with it, but if they have problems with incontinence, and this is tying into what you're talking about as well, Jesse, if they have incontinence, we were putting the cream or the paste on them to protect their skin from breaking down. That makes sense?
Right, and then the ointment is to treat it.
The ointment,
right?
if the ointment has medication in it, it's gonna treat it. You understand what I'm saying? If the ointment has medication in it, like a steroid, let's just say, or if you have nystatin, they have nystatin ointment, they have nystatin cream, which is something that was common. If a baby had a real bad rash, sometimes we will mix the nystatin with a little bit of triamcinolone. That way you got your nystatin for the fungal infection. And we'll talk about the different types. The nystatin covers the fungal infection. What do you mean by fungal infection? If the baby has a rash, it's a yeast rash. A yeast is a fungus. That makes sense? Everybody with me?
Yes, ma'am.
Okay, the triamcinolone is a steroid. That part is going to help with the inflammation. So they were put together. It was a nystatin and triamcinolone ointment. This is just an example of what we would use. So with your Boudreaux's paste, just to answer your question, that's really more of a skin protect to protect the skin from breaking down.
Okay, so that's not necessarily treating skin breakdown. It's just it's a preventative measure.
That's right. That's right. So let's just say it's the same thing with A&D ointment. Yeah, I know because you were talking about putting the Boudreaux's on your baby, right?
Yes, ma'am.
Okay, so that's more of a protective barrier. I use A&D ointment. My baby doesn't have a diaper rash, but I put the A&D ointment on there because it serves as a barrier. It doesn't have any medication in it. It just serves as a skin protective barrier. That makes sense?
Right. So since you would use the Boudreaux's as a preventative measure, what in turn would you use if they already had?
If she had a diaper rash?
Yes, ma'am.
If the diaper rash was bad, you would have to get something like nystatin or something like that.
Okay, so something that contains medication.
And a lot of times, sometimes people will use Desitin. They'll use Desitin.
Oh, right.
Which is an over-the-counter. And it has a little medication in there that serves as that helps heal up yeast as well.
Got it.
Okay, everybody with me? Does that make sense?
Yes, ma'am.
Okay, all right. Just let me know if y'all need anything. I'm just trying to. Okay, so any kind of lesson considerations with our adults, they have less moisture, so that's why we're using our ointments to keep it moist. That's why we're using Vaseline. That's why if they have to have any kind of ointments or anything put on, that's why, because we're using that ointment as a vehicle to deliver the medication we need. They need increased time to heal because their skin is thicker. And so you have some people that may have diabetes, that may have calluses. That, you know, the medication you have to get that off of there before you're able to even apply the medication. So you won't be doing it, but a podiatrist or whoever the case may be would do it and order the medication. They have increased chance of skin tears. Their complexion is paler. And that's why we always try to tell older patients, especially, and if you're fair skinned, to stay out, don't get a lot of sunlight. You know, don't do a lot of sunlight because it can damage your skin. So any kind of age spots, liver spots, nevus, anything like that, increase the number of freckles, all this kind of stuff just kind of puts you at increased risk for problems with your skin. So we just always try to tell you, make sure if you're out that you can use some kind of what am I trying to think? It's right down the tip of my tongue. Skin protectant. If you're gonna be at the beach or whatever the case may be, we always try to tell you to put on the suntan lotion or whatever the case may be to keep your skin from being burned. It makes sense?
Yes, ma'am.
Yes, okay. Okay. So any kind of considerations, I also want to look at any kind of wrinkled skin or sagging skin, any kind of decreased skin turgor. What does decreased skin turgor mean?
Dehydration.
Okay, so and when you have dehydration, what is it easier for you to do? For that skin to do what?
Get dry.
Dry, and it'll start cracking, right?
Yep.
So we got to make sure we pay attention to that. Any kind of increased bruising or discoloration, and it also increase your risk for injuries. Because now let me say this, I see this a lot in the hospitals. If you have somebody that's on blood thinners, do you have to be careful with them bumping into things or them bumping their arm or whatever the case may be? How important is that?
That's extremely important.
It's extremely important. Why is it extremely important? Because what?
Because they can bleed out.
They can. So let me ask you this, and I think I had a student ask me this one time. The person was on blood thinners, and the patient wanted to be shaved. Now, how do you all feel about that?
Bad idea.
You gotta
Why?
use a razor.
Yeah. So this type of person may want one of those electric shavers. You understand what I'm saying? You wouldn't want to use a razor shaver with this, but with a person that's on blood thinners. You may want to use the electric shaver. Does that make sense? The one that you just kind of rub on your face?
Yes, ma'am.
Yeah, you wouldn't want to use a blade with this type of person. So you're going to ask any kind of questions, and we talked about this, asking any kind of question related to how long has it been there? When did you notice it? Have you had it done before? Did you ever have to have it removed? Whatever the case may be. You want to check the color. You want to check the texture and the turgor. Is it moist? Is it dry? You want to look at the temperature. Is it cold? Is it warm? If somebody's extremities are cool, what could that be giving me an idea that what?
They have poor circulation.
Poor circulation. There we go. So if we have poor circulation, we bring that person is more at risk for that tissue doing what, Megan?
Breaking down.
Mm-hmm. So any type of edema, Cody, if we got increased edema, why do we get concerned about edema? Because what? Why do we get concerned about edema? If your leg gets so big and so edematous,
Blood flow.
that and what else? What else can happen if you start having a lot of edema in your extremities?
Tissue death.
Say again, Aaliyah.
Tissue death.
And it'll do what? It'll break down, it'll open up, and then you'll start seeing what? What we call weeping. And weeping is when the tissue, the inside of the tissue, it breaks open and it starts leaking out of the skin.
So basically it stretches the tissue.
It does. It does. And all that stuff starts pouring out or leaking out. So you'll find yourself, if you don't put them in one of the absorption pads, you'll find yourself changing linen constantly. Any type of lesions, if they don't get better, they can get worse. and you never know, the infection can travel up that person's extremity, and before you know it, the whole extremity could have to be amputated. So we have to assess any kind of rashes, lesions, any kind of open wounds. We have to assess those things, because the main thing is we definitely don't want any bacteria getting in there. We don't want anything getting in that area. Is everybody with me? Anybody got any questions as of right now?
What did you say about lesions? It's like,
If you're having the lesions on there, we're going to talk about furuncles and carbuncles in a minute, but if you're having the lesions on there, those lesions are full of bacteria. And so if we don't take care of those areas, or we don't do our wound changes, we don't address it properly, the infection can spread up that limb. And I said, you know, before you know it, the whole limb has to come off, because you can't, it's not healing up. And so if it's not healing up and the tissue is dying, you got to get that dead tissue off of there. It's not serving a purpose.
okay, thank you.
You're welcome. Everybody with me? Anybody else got questions? Where am I? Okay. So education, we want to make sure we educate the patient. Educate the patient on how to properly take care of the wound. Educate the patient on what they need to put on there, what they don't need to put on there. And a lot of times people learn from demonstration. Now, you may have patients that are unable to answer you. They're unable to do their own wound care, whatever the case may be. And so we may have to teach family members, or we might have to make sure that home health is coming into this patient's home. Now, whose job is it to make sure that we get in touch with home health and all that kind of good stuff? Whose job is that?
Nurses.
Okay, so if the physician or whoever the provider orders home health, we have to make sure that we call and, you know, get it clarified of who the patient is, and they may, you know, ask of us for some information regarding this patient. We have to send over to them. So that's going to be part of our job, is making sure we're educating the patient if they're going to be using family member at home, or if they're doing it themselves, making sure they understand exactly what we're doing. Then we also need to make sure they have some type of support there to make sure that it's getting done. Because a lot of times people are not able to do their own wound care. They may say they're doing it, and then you get in there and the wound looks way worse. I'm talking about where the person has to go from being at home to now we got to put you in the hospital because it's gotten so bad. So when you do your documentation, make sure you document where the area is, what it looks like, how big is it? If it has any drainage, what color is the drainage? Does the drainage have an odor? Is the area tender? Is the area red? Is it swollen? All the signs of infection are things that we want to make sure we document, because if a wound is not infected in the beginning, we need to be able to be conscious and pay attention, so we'll know when the wound starts to get infected. That way we can cut it off before it gets too bad. That makes sense? And then we want to monitor our results. If we know a patient has had a wound or a surgical incision or something like that, it should start getting better. We don't want it to head in the wrong direction. So that's why we got to make sure we keep our eyes on it. That make sense?
Yes.
Okay. We're looking for a white blood cell count. Why are we looking for the white blood cell count? What is that going to tell us?
Infection.
Infection. Okay, what's the normal white blood cell count?
4.5 to 10.5.
All right, and then depending on what hospital you have, they may lower that spectrum on the beginning, or they may make it a little higher on the end. But you can tell when that white blood cell starts climbing, something that's going on. Why is hemoglobin and hematocrit important?
Blood circulation.
Yeah, it tells us whether they got enough blood in their system to even circulate. Because if your blood is low, how can we expect for it to circulate throughout your body if you don't even have enough? That makes sense. And then we also want to look at our PT, our PTT, and our INRs. Okay? So any kind of serum protein, albumin, and any kind of sensitivity studies. Now let me ask you all this question. What does the body need to make sure that it heals a wound?
Protein.
Protein. So if the person's not eating, how are they going to help heal the wound? So who will we need to make sure is on board if a person is having a problem with their diet? Who do we need to make sure is on board?
Dietitian.
The dietitian, there you go, dietitian. Now, in some facilities, not saying that they're in all facilities, but in some facilities, they have this stuff called liquid gold. And it's a protein supplement that they'll put in for the patient. You can put it in a person's drink or whatever the case may be, where it's a protein supplement to kind of help build up their albumin and stuff like that. And then they also have Juven, which is a powdered substance that you can add to a liquid and have the patient drink that as well. Now, it is no good for the person to have these things ordered and never make it to them. It's called Prostat. Prostat. They got Protein Gold. It's all different names. But thank you, Brittany. I guess at the facility where Brittany is, it's Prostat, but we have it as Pro Gold at our facility. It's gold, Protein Gold. So they have different names for it, but it all serves the same purpose. And you're just trying to increase this person's protein that they're not generally getting through their diet. That makes sense?
Yes, ma'am.
Okay. All right, so if you look at this chart, at the top you got your skin integrity, and this is a good little chart. So if y'all want to take a quick snap, I probably would. This is a good little chart, and if you look at it, at the top, it's saying skin integrity, and it gives all these different things that can affect it. So if you look to the left of your screen, it's saying your activity level is affected by any kind of mobility or level of independence. Now, if you look at the right, if you got existing integrity, then you got to be looking at your skin turgor in the presence of any wounds and pressure points. So if you've got somebody that has pressure points, and pressure points could be anywhere. Y'all take me some pressure points.
Lower back of the heels.
Lower back. What else?
Elbows, ankles,
Elbows.
Heels.
Heels.
Behind the knee.
Behind the knee.
Sometimes the
Right,
butt.
now look, let me ask y'all this. You said, who said behind the knee?
Carmeria.
Oh, Carmeria, let me ask you this. Now, when I'm talking about pressure points, I'm talking about the points of where if you don't move this person, they can have some breakdown. There's more so of a bony prominence.
Between the knees.
Okay, okay. I thought you said behind. Okay, between the knees, where else?
Behind the head.
Behind the head, where else?
The tip of the ear.
The ear, and let me say this right here. How many people have noticed that the bridge of the nose, when the patient has on their oxygen cannula, the bridge of the nose, if it has pressure on it for too long, it can also cause it to break down. So any area that has pressure on it for too long amount of time can cause breakdown. Now, for the person somebody said something about elbows, right? Who said something about elbows?
Jennifer.
Okay, so Jennifer, when you said elbows, talk to me a little bit about the elbow part of it. Talk to me about that. What do you mean?
Like if they're laying on their back and their elbows are laying on the bed, that and the skin over the elbow, there's not much meat over the elbow. So it's a very bony prominence.
So what would you do in the case of that? What would you do? If you came in and saw somebody that was having problems with their elbow or their elbow was red, what would you do? What is something that you could do?
Maybe like prop their arms up on, like prop it up on a pillow to where it's not laying directly on the bed.
Good. So let me ask you this. If I came in and I want to hear I want to get a lot more people to get involved with this one because this stuff is really easy stuff. Let me ask y'all a question. If you came in a room and you noticed that Mr. Billy Joe was laying down in the bed, and you noticed that it was Mr. Billy Joe was having some redness to his left hip, what would be the first thing that you would do?
Rotate.
Came in the room, noticed Mr. Billy Joe had some redness to his left hip. What would be the first thing you would do?
Get him.
Rotate him.
Assist.
You're gonna assess it, but what's gonna be the first thing you're gonna do? This got some substance to it.
Reposition.
I'm gonna change his
Okay.
position. I'm gonna change his position. You said that, didn't you, Jesse?
Yes, ma'am.
Okay, you gonna change the position. If I saw some redness on Mr. Billy Joe, would I run out and say, well, look, wait a minute, I need to call the doctor right quick and let him know Mr. Billy Joe got some redness on him right now. I need to get. Would that be something that would be the first thought in my mind?
No.
So I want y'all, when you start thinking about when it's time to call folks, you gonna call them. Yeah, you gonna let you. I wouldn't call them about that. Wound care would be the person you gonna let know such and such has some redness. But if they've got some primary stage 1, which is just that redness there, if you move that person out the air, you'll start seeing that part resolve. Does that make sense? So I just want y'all to get comfortable with knowing, okay, if I see Mr. Billy Jack got some redness to the hip, I ain't gonna leave Mr. Billy Jack like that and go call and tell the wound care nurse that I'm gonna change his position first. Get him off of that side so that it can help resolve that redness. That makes sense?
Yes, ma'am.
Yes, ma'am.
Okay. Yes. Anybody got any questions for me? Because we finna get into the meat of this and wrap this thing on up. So anybody got any questions about what we talked about?
Dr.
So,
I do have a question.
Who is that, Camaria?
Uh-huh.
Okay, go ahead, Camaria.
So as far as, and I think I'm in the past I had issues as far as, okay, so with the wound care nurse, I know we don't have to like get any orders from the provider to consult with the wound care nurse. Like, you know, especially if it's no longer stage 1 and it has progressed, or do we need to speak with the provider first before we go to the wound care nurse?
Okay, so what's gonna happen is if you're in a room, let's just say you're taking care of a patient and Mr. and Doctor, well, I'm gonna say, look, you know, I'm big on nurse practitioners, so I'm gonna say that the nurse practitioner is the provider for the patient. Okay, and she comes up and you tell her, she gonna say, well, who has the patient in 10? You gonna say, well, I had the patient in 10. Okay, she gonna say, well, tell me what's going on with the patient in 10. You gonna give her a rundown of what you got going on, and then you gonna say, well, I've noticed that Mr. Jack has some breakdown to that right hip. She gonna ask you, well, is the skin open? Is the skin broken? Well, yes, it's a stage 2, whatever the case may be, stage 3, whatever the case may be. It's 9 times out of 10 if you just notice in stage 2. Okay, he's got some breaking to that left hip. Okay, what she's gonna do is she's going to write an order to consult wound care. So once she writes that order to consult wound care is what's handling that wound now. You understand what I'm saying?
Okay, yes, ma'am.
Does that make sense?
Yes, ma'am.
Everybody understand that? So wound care is the one that's handling. Okay, so let's just say as an example, wound care has nurse practitioners, they may have that or providers that come in and actually that's all they do. They take care of wounds. So wound care is gonna be the person that's gonna be writing how you're gonna take care of this wound. I want you to clean it with this. Q12 hours. I want a wound vac put on there. Or I want you to do a wet to dry dressing on this twice a day. Sometimes they may say every 48 hours. It just depends on whatever the order is written. But once you tell the primary provider about it, they're gonna write an order to say consult wound care.
Okay.
And then wound care is the one that'll be taking care of that from then on out.
Okay.
Okay, that makes sense?
Yes, ma'am. Thank you.
Okay, everybody good with that?
Yes,
So if you all looked at your objectives before now, which I'm hoping that you did, don't tell me that you didn't, you will see that our 2 exemplars are contact dermatitis and cellulitis. Okay, so if you've been asleep this whole time and you've been in la-la land, you probably want to wake up, because if you got any questions, now's gonna be the time to answer. Okay, so contact dermatitis and cellulitis. All right, so with contact dermatitis, this is a type 4 delayed hypersensitivity reaction, and if you go back and review your notes from Miss Gordon, it'll give you a little bit more in depth on what it is. Now, this is just good food for thought of what I'm talking to you about now. You've got your allergic, you got your irritant, you got your phototoxic, and the phototoxic and the irritant kind of resemble one another. And then you got your photoallergenic, which resembles the allergic type. So for this lecture and for testing purposes, we're gonna cover some allergic, we're gonna cover the allergic and we're gonna cover the contact as well. A lot more of it is gonna be more specific to contact, okay? So we ain't gonna be talking too much about no phototoxic and photoallergenic. I'm not gonna be talking about, I was just giving you the different types, okay?
I have a quick question.
Understand it.
Yes, can I ask a question before we go to the next slide?
You sure can.
Okay, so the hypersensitivity reaction, I know we did that earlier in the semester. And you kind of just said this, but I just want to make sure. So for testing purposes and whatnot, is that really, do we just need to know the ones that relate to contact dermatitis and not the other ones necessarily?
Listen, Kaylin, that's just good food for thought. I'm telling you what type of reaction it is. Don't lose no sleep trying to hunt it down.
Okay, thank you.
Okay. Everybody got that?
Yes, ma'am.
All right. So when we talk about the irritant contact dermatitis, it's an inflammatory skin reaction to any kind of physical, chemical, or biological agent. So that's just like people going outside and you working out in the yard and you get a hold of something that irritates your skin. That makes sense.
Like poison ivy?
And you'll start itching. You may not have an actual reality, or you may look down and just notice that your hand is red. So poison ivy is more of a, it's a contact dermatitis, but it just depends on what level it is. Because sometimes you'll look down, you may get a hold of someone, you may get a chemical on your hand. Who was that asking me? Jesse?
Yes, ma'am.
Okay, you may get a chemical on your hand, and you may not have any itching, you may not have any ooze and none of that. You just may look down and your hand may be red.
Okay, got it.
You understand what I'm saying? And some people, like, they can't wear nickel. They can't wear any kind of nickel jewelry. They have to wear real jewelry. If you look down, you may just see your hand is red. That makes sense?
Yes, ma'am.
Okay. Hold on, y'all. I'm still trying to work with this computer. Does anybody have any questions for me up until now?
I do. So would that kind of fall into the same category as people who have sensitive skin and have to use like unscented soaps and stuff?
It just depends on if it causes them to have a rash or reaction.
Okay.
It just depends on if it causes them to have a rash or reaction, because sometimes people can control it by not using any kind of lotions or scented soaps or anything like that, perfumes. And we'll talk about that in just a little bit, Megan. But it just depends on to what extent that it causes them problems.
Okay, thank you.
So this is more like warmth and redness instead of like a breakout.
Right. It's just red. Yeah, you may see that, you look down and see it's red, or that it's starting to swell or something like that. It's not where it's itching, where it's breaking, where it's itching so bad you got to break the skin.
Got it.
Okay. So something that we always want to make sure, y'all, that we tell somebody if they've got contact dermatitis or anything like that, is that they keep their hands lotioned up and keep it moistened up. And that's mainly because if it dries out, it's going to start doing what?
Cracking.
Breaking. Because you're going to be scratching it, right? And it's going to cause it to break. And then once you cause it to break, I told you earlier that all of us carry what on our skin?
Bacteria.
And what specific bacteria do we carry, Megan? Staph. And so staph is all right on the outside of the body. Staph becomes a problem, y'all, when it gets on the inside of the body. So if you got somebody that's scratching their skin or breaking their skin, or somebody that's been bit by ants or bit by, the main cause a lot of times is staph. So when we do our antibiotics, or when you're talking to a patient about making sure they're taking their medicine, they may say, well, why am I taking this medicine? But some things are only specific to certain bacteria, and so we prescribe medicines only specific to staph. So when we go swabbing stuff, we're swabbing it because we want to know what kind of bacteria is growing. So just kind of make sure all this has to tie in together when you're talking about this dermatitis, because you want to prevent the person from even getting to the point where they got to be scratching and itching and breaking skin and all that kind of stuff. It just all ties together. So just make sure you tell them to keep their skin and stuff moisturized. Okay, so any kind of common causes for this, as you said earlier, y'all, was soaps, scented soaps, all that good smelling soap, y'all, that had you smelling so good, detergents, any kind of cleaning compounds or industrial compounds. So let me say this right here. What would be a profession? Who had not called on? Y'all just call it out because I can't see your picture. What would be a cleaning profession? Well, I mean, what would be a profession that may have problems or using cleaning stuff? Who would I have to be worried about?
Janitors?
Janitors, who else?
Housekeeping in like hotels and stuff.
Housekeeping, hotels, it may be even at home. You may have somebody come into your house and keep your house clean, or there may be a homemaker service for a patient that is at home. They have these services called homemaker services where they come in and clean up for you. They may cook a meal for you, whatever the case may be. So you have to just make sure you look and identify what professions may be at increased risk for that. And then you got your industrial compounds, people that work with a lot of chemicals and stuff like that.
Couldn't we be at risk for it? Because I know when I clean my bathrooms, I think I want to die.
Well, yeah, we could be at risk for it. And not on that, nurses are at risk for it a lot too, because when you get there and you start using those chemicals and stuff in your hand, you wash your hands a lot, number one. You use a lot of the hand sanitizer. You use a lot of the stuff that they have hanging on the walls. All those things are alcohol based, and sometimes people can be allergic to that. Okay? So y'all just make sure y'all pay attention to that too. So, and anybody can answer it, because like I said, I can't see y'all. Anybody can answer it. But why is it so important that we tell you hand sanitizer is good until you do what? Until you can get to what?
Soap and water.
Soap and water. So a lot of times we think, oh, I use hand sanitizer and that's it. You know, we going about our merry way. But hand sanitizer only serves as being sufficient until we can actually get to soap and water. Okay? And with us as nurses washing our hands so much, that dries our skin out. We got to make sure we do what?
Moisturize.
Moisturize. Moisturize. Very good. Anybody got any questions on it? Ask away. Okay. Some of the things that you're going to see is pruritus. What is that? What is pruritus?
Itching.
Itching. Very good. Itching. Itching. Come alive, y'all. Come alive. Burning. Any kind of erythema. What is that? Redness. That's right. And then edema. You got papules. Those are going to be elevated. And you may see where they may have the little circumscribed borders, y'all. And then you got your vesicles. And there's a difference between your papules and your vesicles. The vesicles are fluid filled. So this means that this person has had a good reaction to whatever it is they come in contact with. Okay, so those are the ones that you may be able to take the fluid out of, and they could be you could have some oozing and weeping there.
Is that kind of like an ant bite, like the little things you get if you get an ant bite?
If it gets bad. Because, you know, not all ant bites cause you to have, you know, those blisters or whatever the case may be. But if you're allergic to them, then they can cause you to have those fluid-filled blisters. Do we want to burst those?
No.
Okay. Any kind of blisters, do we want to burst those?
No, ma'am.
Okay, because the blisters serve as a what?
A protective mechanism.
There we go. There we go. So who's at risk? We said we're at risk. Nurses, we're at risk. Food workers, hairdressers, and cleaners. So with the irritant, you're going to use any kind of compresses. If it's an irritant, petroleum-based emollients. That's just ointments. And the petroleum, which is Vaseline pretty much, is used as the vehicle. And then you may have to use some kind of hydrophilic creams, just depending on how thin the person's skin is. Topical corticosteroids, that's going to be our triamcinolone. We may use that. That's a popular one. Any kind of antihistamines. And then guess what? If it gets real bad to where it turns into a staph infection, we got to throw some antibiotics in the mix. So Keflex, whatever the case may be, sometimes they'll use Cipro if it's a bad. We might throw that in there to kind of add to it. But the main thing that's going to treat our problem is going to be steroids if you got an irritant contact dermatitis. Antibiotics are only used when it becomes a what?
Infection.
Infection. So let me say this, and anybody can answer this. So just because I got a rash on my arm, am I going and expecting to, do I have to go to the doctor for that, the rash on my arm?
No.
What can I try first?
Hydrocortisone cream.
And they got that over the counter, right? So if you put your hydrocortisone, which is a topical steroid, on there and it doesn't help, then you'll move on to the next step. And so you just always want to make sure that you let your patient know they need to keep their area nice and clean and dry before they put new medication on it, okay? So that's going to be something that you always want to make sure they know. It makes sense?
Yes.
So if I had somebody that had, let's just say somebody had MRSA of their arm or their leg, what type of contact with this person, what type of isolation would this person be on? Contact. I gave you the answer. Okay. So everybody understand about the irritant. And then we'll do a quiz at the end, just kind of make sure everybody know what they need to know. So any kind of sensitizing agents, plants, chemicals, this is what we talking about, that poison ivy, Jesse. Plants, chemicals, drugs, foods can also cause it. You know you're allergic to seafood and you go in and eat shrimp, you're probably gonna have this problem, okay? So you're gonna have your itching, your burning, your erythema, same thing, skin lesions, edema, weeping, crusting, and the crusting comes after the weeping has dried up, and then it just kind of dries off and it peels away. In a good scenario. So with that aluminum acetate, if you got something allergic, a lot of times we'll tell you to use Burrows solution or whatever the case may be. Cool water compressor because you're trying to calm it down. But guess what? What do you all see that's familiar that we just talked about a little while ago with irritant?
Antihistamine.
Antihistamine and what else?
Corticosteroids.
That's right. That's right. That's right. You're going to focus on their chief complaint. If their chief complaint is going to be itching or rash, you want to know where it is, when did it start, have you had anything to eat, have you been working out in the yard, have you been using a different chemical, have you used anything different on your hair, have you started bathing with anything different, have you used a different detergent when you're washing your clothes, what have you used different that you hadn't normally been using? That's what you're really searching out for when you're interviewing this patient. You want to know when it started, does it itch, does it hurt? Does it sting? Does it burn? Have you had this before? How long did it last then? What made it go away? How severe did it get? Did it get as bad to where you had to get a Decadron shot? Did you have to get be on any kind of medication, a Medrol dose pack? What did you have to do the last time this happened? And then any kind of precipitating, what makes it worse or what makes it better? Everybody with me? Stop me if you're not. Everybody good?
Yes, ma'am.
Okay. Okay. So nursing diagnosis you can use, and I want y'all to pay attention to these nursing diagnoses and see how they look. Impaired skin integrity related to contact dermatitis as evidenced by, how do I know that they got impaired skin integrity? I see a rash, they having itching and a rash. So y'all look at that. Make sure y'all pay close attention to these nursing diagnoses. If the person actually has it, it's going to have the actual diagnosis related to and then as evidenced by. If the person is at risk for it, it's just going to be the diagnosis you're using related to. It's not going to have it as evidenced by with a risk for. It's not going to have it as evidenced by because you don't have anything to look at. Does that make sense? I want y'all to speak to me about that. Does that make sense what I'm saying about that? Nursing diagnosis.
Yes, ma'am.
Everybody got a good idea of what I'm saying.
Yes,
so when you're doing your the actual thing has 3 parts. If you're doing a risk for it, only has 2. So if you're saying the person has impaired skin integrity, what is that related to? It's related to their contact dermatitis, as evidenced by they're itching and they have a rash. That's how I know it's impaired. That makes sense? Does that make it a little better?
Yes, ma'am. Dr. Laws.
Who is that talking? Cameria?
Yes, ma'am.
Okay, Cameria, go ahead.
So, like with the nursing diagnosis, like I know there are so many. So as a nurse, like for instance, will it always be something that's out of the book, or is it something that we could, and I don't want to use the word make up, but it's like relate, like the contact dermatitis. That's just something that's not a medical term, is what I'm saying. Like, is
Right,
it
it's not a medical term. It's really just validating it's really just validating saying, how do you know this person has impaired skin integrity related to how do you know that? Because they itching and they got a rash.
Right. So it doesn't have to always do, like, it doesn't always have to be related. Like, we don't have to use in our nursing diagnosis related to like a medical term. It could be something.
Well, a lot of instructors don't like for you to use, medical term. Now it just depends on if that's what the
Mayday is one of them. You're not allowed to use medical.
Look, she done came to life, y'all. But let me say this: if the person and I always tell people this because I've noticed that we always go for, and when I say we, I'm talking about y'all. We always go for the easy ones. Always safety. This. Okay. But if the person is in there and that person has a problem, you need to go as close to what the person's main problem is. What do we need to make sure we pay attention to while the person is there? Because the care plan is generally done by whoever does the admissions on the patient. But the interventions and stuff are stuff that we carry out. You understand what I'm saying? And then if the person happens to pick up new problems, then that's stuff that we have to develop a care plan for. How are we gonna take care of this issue? You get what I'm saying?
Right. And I guess what I'm asking is like, and like you said, like a lot of we use the same terms, but I'm saying like, could it be something that we kind of is, and I don't want to say made up, but it's just based off our observing. Like, for instance, we didn't get it out the book. Like, even though it could be.
Give me an example. So give me an example, Carmiri. Give me an example.
Okay, so like this one, impaired skin integrity related to the contact dermatitis. Like, I feel like I don't think I would have seen that in the nursing diagnosis book. I feel like that's something that the nurse came up with herself.
Actually, it's not though, because that's why the person has it. If the person has impaired skin integrity, why are you saying they have it? The contact dermatitis is the problem. That's what's causing them to have it.
The contact dermatitis is what I'm saying. I'm speaking on that part.
That's
what I'm saying. I'm like that part, that contact dermatitis. That's, I guess it's just based off of what we see then.
Exactly. And it has to be based off of whatever your scenario is. Because when you're looking at what's going on with the patient, if the patient is in there for something that's major, and this happens to come after, let's just say they come in contact with a chemical or something. This may be included, but it may be down on the totem pole. You understand what I'm saying?
Right.
You got to go with what's most important. Now we're using this because I'm talking to y'all about skin integrity. So that's the reason why I threw this in there. But the main thing is going to be making sure that you can't just make something up. It's got to be evidence to support it. You get what I'm saying? And if you went on the contact dermatitis, you would see this nursing diagnosis.
Okay.
Because that's because that's going to be one of your main issues with somebody that has contact dermatitis, is the fact that you run a risk of them breaking the skin. So you're going to see this. You're going to see this you're going to see this for a nursing diagnosis.
Okay. And that's what I was saying. I didn't know if it was something like I know it would be related to what we see, but I didn't know if we would actually see contact dermatitis in the nursing diagnosis, or, that's something basically what we kind of, our own terminology that we use based off of what we have observed.
No, you'll see it, because they're gonna put in the diagnosis of contact dermatitis, so you're gonna know. And then let me say this right here, y'all. Y'all have it good for the ones that have like computer stuff. Everything has gone to computer, so I guess I could say it's good and bad. Everything has gone to computer and it's generated in the computer. So when you go to your computer to do your stuff, depending on what hospital you go to, the care plans, if you put in a key thing, you may put in contact dermatitis, generate some nursing diagnosis for you. You understand what I'm saying? When we were in school, it didn't do that. We had to come up with our own. And so the reason why we're teaching you how to do this is because guess what? Computers break down, just like we got stuff that people are working from home, computers break down, all this kind of stuff go on. You may not have access to it. So you still need to be able to document, pen and paper, handwriting on the paper, if you ever got put in that situation where you had to do it. My clinical group, nothing was generated on computer because we didn't have computers. So everything was built from what was going on with the patient. Did that make sense?
Yes,
And
ma'am.
Kamiri, I'm hoping that I'm answering. Am I answering your question?
Yes, ma'am. I do understand it has to be related to, you know, the problem, the issue. I was just wondering, is it going to always be something that the nurse will find out of the book, or it be something, and sometimes we will have to kind of put together ourselves relating to that?
No, a lot of times you'll have your the main thing is gonna be getting your diagnosis you want to use.
Yes, ma'am.
That's gonna be the main thing. And then your diagnosis, when you put your related to, is just supporting why are you saying this person has this.
Yes, ma'am.
You understand what I'm saying?
Yeah, I do.
Is that helping anybody else? Because if you ain't got it, come here, I want to make sure you get it. Because I know, ma'am.
I get it. Yes, ma'am.
Okay. Anybody else have any issues with that?
Can I ask Dr. Mayberry a question?
You can.
Dr. Mayberry, would you allow us to put contact dermatitis on our nursing diagnosis, or will we have to put something like inflammation of the skin?
I'm trying to mute my mic. I would take contact dermatitis.
Okay, I just wanted to clarify.
Mm-hmm. All right.
Jesse.
Ma'am.
This my show. You can't ask Dr. Mayberry no question.
All right, I'll keep that in mind.
I'm just kidding. She on there, so if y'all got
whatever you like, I'm here.
That's right. That's right. If she on there, you should ask her. So any kind of client education, you got to avoid. You got to make sure you remind the patient avoid any kind of contact with irritants, especially if it's the ones that you know irritate your skin and you've had a problem with in the past. So you want to ask them avoid any kind of heat, soap, any kind of rubbing, anything that can cause friction or cause you to have problems with your with that area. And then choose bath soaps that don't have a lot of perfume and fragrance and all that kind of stuff in it. They have laundry detergent out now called All Free and Clear that doesn't have any type of perfume or anything like that, and it's really good. And then any kind of cosmetics. So you just have to make sure you pay attention to those things. But that's why the assessment and getting the history and paying attention to what your patients answer or say is going to be super important, because that's what the provider is going to use to guide their practice and their decision making. Okay, so you're going to be the one collecting a lot of information. Avoiding kind of fabric softener, dry sheets. And let me tell you this, I know I'm going to get in trouble with this one, but I'm going to specify why I said that topical medications, lotions, or ointment, unless they're prescribed. Okay, so this is if the person is actually in the clinical setting. Now, if you're at home, and I told y'all just a little while ago about hydrocortisone over the counter, you're not prescribed hydrocortisone over the counter. You can get it at the store. So this is just telling a person that has been seen in an actual facility, unless you've been prescribed this medication, don't use Mr. Sally Sue stuff from down the street. Do that make sense? Y'all talk to them. Okay, so let me give you a scenario to break it down. Okay, little Jilly is going to, let's just say little Jilly is going on a trip to the zoo with her class. Okay, little Jilly gets there and she comes in contact with some grass or something that breaks her out. And little Jilly's mom knows that she always has a problem with grass and being outside and stuff, but she can't keep little Jilly from going on a trip with her class. She's been waiting on this trip the whole year. So she's saying some hydrocortisone with little Jilly. Am I going to tell little Jilly not to use the hydrocortisone?
No.
Y'all talk to me, yes or no?
No.
Huh? Why y'all quiet? Y'all talk to me. Am I going to tell little Jilly don't use the hydrocortisone? Okay, so why not? Because what?
Yeah, the grass irritates her skin.
And she bought it with her because guess what? She's had this problem in the what, Sarah?
In the past.
In the past. So that's why I'm sending the hydrocortisone with little Jilly, because she's had it in the past. Okay, let's just say that it gets real bad, Sarah, and little Jilly has to go to the dermatologist. And the dermatologist said, well, I'm going to give you this prescription for a triamcinolone now. Is it okay for me to tell little Jilly, don't use a hydrocortisone anymore, use the triamcinolone?
Yes.
Yes. Why, Brittany?
Because it's a prescription.
It's a prescription. So when I say this, avoid topical medication and stuff like that, I'm not saying if the person is at home, whatever the case may be. I'm talking about if somebody else has told them, if they've gone to an actual clinical setting and got a prescribed topical medication, that's what you're going to use.
Dr. Lyles.
Who is that? Brittany. Okay, go ahead, Brittany.
Oh, I got an example. Like, I have eczema and my little sister had eczema, but she would get prescribed the ointment and I would get prescribed the cream. Is it because hers was more exposed, or hers is worse than mine? Is that why she got the ointment versus I got the cream, and they told us not to share our cream?
Right, because the ointment is more potent, which means that the ointment has more medication in it, and it'll penetrate better.
Okay.
That makes sense?
Yes, ma'am.
Okay. Anybody else had any questions? Because I think that was a good example, Brittany. Anybody else got any questions in regards to that? Because I want to make sure y'all understand it now. Y'all good?
Yes, ma'am.
Make sure you wash your hands good immediately after you done got exposed to whatever it is. You need to make sure you wash your hands good. And if you can, put some gloves on. You know, if you're out somewhere where you can wear gloves, you need to do in a hospital or whatever case may be, stuff like that, you need to put gloves on. Sometimes gloves can cause and serve as an irritant as well. So that's why everything is latex free now that you'll see in the hospital, because a lot of people are allergic to latex. So you want to make sure you let your patient know, can you tell me any signs of a bad reaction, signs of infection, signs of wound infection? They need to know that, because if they have a bad reaction, you tell them, just regularly put your topical antibiotic ointment on there or whatever, or take this, and all of a sudden the person gets to where they can't breathe, they're having an anaphylactic reaction. Don't you think that topical steroid is not going to help that, right?
Right.
Right?
Right.
Okay.
Right.
Any kind of signs of infection mean, hey, we in a whole nother ball game. It's now all of a sudden I've been scratching it so bad. Now all of a sudden it's got this green drainage coming from it. It's got this yellow drainage. It's starting to smell. It's soaking through the Band-Aid. Those things are not normal. So we need to seek out, you need to go see somebody. So you always want to make sure, this is our role as nurses, to make sure that we tell our patients this. Okay, knowledge check. Let's see, who have I not picked on? Well, I guess I can't see you. I can't pick on none of y'all. We're going to see if y'all can answer it. A nurse is for a client who is scheduled to undergo diagnostic testing to determine the cause of dermatitis. When educating a client about diagnostic testing, which statement by the nurse is appropriate? So y'all just call it out.
A.
Who said A?
No, sorry, no, that's not. I don't want that one no more.
So that means that this person is basically having, when we say diagnostic test to determine the cause of dermatitis, when educating the client about diagnostic testing, which statement by the nurse is appropriate? So I talked to y'all about earlier saying, if we're doing some diagnostic tests, because I don't know what you're allergic to, you're 9 times out of 10 getting a what kind of test?
A patch test?
Okay, a patch test. So with the patch test, what do you do with the patch test? What did I tell you do?
It's gonna be
Put it on the skin. It come in contact with the skin.
Okay, so would I say the patch from the patch test is usually removed after 2 weeks?
No.
Okay.
It's
Would I say the skin is pricked and a skin injection test are used to test for delayed reactions?
Yes.
What about you may shower or exercise while the patch from the patch test is in place?
No.
Okay, so let's see what the answer is. Y'all ready? A. Now, in patch testing, I told y'all that you're going to place it on the person's, they're going to 9 times out of 10 be on their back. Okay, it's usually removed after 48 to 72 hours. So the skin prick and skin injection tests are only used for immediate reaction, because you got to think about it. If when somebody goes to get allergy tested, we try to see if they have an allergic reaction to it right then. And our purpose for this is desensitizing the person to whatever it is they're allergic to. But we got to find out what that is first. So the client should not shower or exercise to the point of perspiring while the patch from the patch test is in place. Why? What'll happen?
Will be invalid.
Right, or it may come out. Okay, a nurse is planning care for a client with contact dermatitis. When conducting discharge teaching, which statement by the nurse is appropriate? Do we tell them we want them to bathe or shower twice daily to reduce allergen contact? Does that sound right?
No.
Okay, what about avoid the use of all lotions?
No.
When using steroid ointments, use a thick layer on dry skin for maximum absorption. Or use steroid ointments for 2 to 3 weeks for best results.
Yes.
Which one y'all say?
D.
Okay, let's see if you're right. Where's my little thing? Hold on, y'all. Uh-oh. Y'all didn't see that. D. When educating a client regarding contact dermatitis, the teaching should focus on home care instructions. So we told you to make sure that the person uses almost for 2 to 3 weeks. They need to make sure they use it until it's gone. One week might not do the trick. So they need to make sure they use the prescribed medicine as prescribed. So the steroid ointment should be applied in a thin layer. You ain't got to cake it up on damp skin, not wet skin. The client does not need to bathe or shower twice daily, because that ain't gonna do anything. You can't tell somebody to avoid all lotions. That was a key word that none of y'all should have picked at all. Some lotions with perfumes or dyes may irritate the client's skin. However, dry skin causes itching and places the client at risk for infection from what? Scratching. Is everybody with me?
Yes, ma'am.
Yes.
Is everybody understanding what's going on up until this point?
Yes.
Okay. All right. We'll keep it moving. A client shows the nurse an area of erythema, swelling, and lesions under a wedding ring. Based on this data, which condition does the nurse suspect? Is it psoriasis? Is it allergic contact dermatitis? Is it eczema? Or is it irritant contact dermatitis?
D, possibly.
Irritant.
D.
That what y'all say? Okay, let's see. B. Manifestation. Remember when I told y'all some people can't wear nickel, they have to wear real jewelry? Manifestations of allergic contact dermatitis. She's showing signs of it. She's allergic to it. She's got the swelling. She's got all that kind of good stuff. Includes erythema, swelling, and pruritic lesions in the area of allergen contact. In this case, it's under the client's wedding ring. Irritant contact dermatitis is an inflammation of the skin that occurs from irritants such as chemicals, soaps, and detergents. Eczema and psoriasis are secondary skin lesions. So does everybody have a good understanding of what irritants and allergic are?
Well, so is the signs and symptoms what differentiates, or is it what causes it that differentiates the the allergen versus the irritant?
It's really going to be the symptoms of it. But I wouldn't. Let me see how I say this. I really wouldn't get myself so wound up on those, because remember we talked about just the contact dermatitis in the beginning. Remember, I told you don't look at all these other little areas. I'm just really in there so that you'll know what allergies, what allergic is when you start having actual symptoms, the erythema, swelling, because just because you get something on your hand doesn't necessarily mean that you're going to have a problem with it. You understand what I'm saying? When we talked about those vesicles and papules and all that kind of stuff, Jesse, remember when I talked to you about that?
Yes, ma'am.
So I wouldn't stay up all night worrying about irritant.
So allergic is more severe than irritant.
Yeah, you're going to actually start seeing some lesions there.
I have a question, Dr. Laws. It's Tatiana.
Okay. Hey, Tatiana.
Hey, I was asking for the contact dermatitis. I know that you said that it's not an allergic reaction and it results in redness and warmth, but the question said erythema, which is redness, right, and swelling. With the
when you get ready to look at that PowerPoint, when you get ready to look at this PowerPoint, you're going to see under clinical manifestations where it's going to have erythema under contact dermatitis. The irritant and allergic are just different levels. They're different categories, different types of contact dermatitis.
Okay, so would the lesions be the reason? The answer is B, because lesions is an allergic reaction. The cause?
No, the lesions are the byproduct of the dermatitis. The person was allergic to it.
Okay.
You understand what I'm saying?
That's why they're allergic, because they are having lesions, right? That's why I'm asking.
They're allergic because they got their erythema, they got their swelling, they got those pruritic lesions. So when we talk about lesions, we talk about either papules or vesicles. So if you look at it, and when I get ready to post this PowerPoint, I want you to go through there and actually look at the difference between allergic dermatitis and irritant. Look at the clinical manifestations of it.
Okay.
One of it, you just gonna have papules. The other one, you may have vesicles and papules. Okay. So when I posted, I want you to be able to look at that. So just kind of go through there and make sure you pay attention to that part right there. But I wouldn't stay up all night.
All right.
I would look at it and differentiate, but I wouldn't pull my hair out. You understand what I'm saying?
Yes, ma'am.
So know the difference between, with allergen contact, you come in contact with something. It could be plants, it could be, a grass, it could be dust. But with irritants, it's gonna be like chemicals, soaps, detergents, stuff that's irritating the skin.
Okay, I got you now.
You understand what I'm saying? Is it making it more clear to you? Because I don't want to get confused.
That makes a lot of sense. I get what you're saying now. Thank you.
You're welcome, baby. Did anybody else have any problems with that?
I had a question. So when you say irritant, are you saying like how you used to tell us like vancomycin is irritant to the body and stuff like that? Is that what you're talking about?
Well, when I talk about irritant, I'm talking about if let's just say I put my hand in some pine sol, just straight pine sol, it ain't diluted. That pine sol will irritate my skin. Same thing as bleach. It'll irritate your skin. It's too strong. So it's a dermatitis because it's irritated me. But with allergic contact dermatitis, it's because I'm allergic to whatever this is. I'm allergic to grass. I'm allergic to dust mites. I'm allergic to cockroaches. I'm allergic to feathers. So me being allergic to this is what's caused me to have this problem. Versus me putting my hand in straight chemicals. The chemicals are what's irritating my skin.
Yes.
Is she the only one saying that it doesn't make sense? Did it make sense to everybody else?
Yeah.
Say no if it didn't, y'all.
Yes, ma'am.
Okay. If it didn't, y'all put in the chat and we'll talk about it.
Dr. Laws.
Yes, ma'am. This Jamie. Okay, Jamie.
I have a question. My internet is going in and out really, really bad. Will this lecture be recorded?
Yes, ma'am. It's being recorded.
And is it gonna be posted to Canvas?
Yes, ma'am.
Okay. That's all I want to know, because a lot of the questions and responses are in and out on my end.
Yes, ma'am. Well, it's gonna be posted to Canvas for you.
Thank you.
You're welcome. Okay, it says the nurse identifies a client at risk for contact dermatitis. Which assessment finding supports the nurse assumption? Select all that apply. So the person is having contact dermatitis, y'all, with a blood pressure of 120/72 matter.
No.
Frequent hand washing matter?
Yes.
Yes.
Would a heart rate of 76 in regular matter?
No.
Cares for plants in a garden, would that matter?
Yes.
Employment as a computer operator, would that matter?
No.
Possibly.
Okay, so let's see. B and D. So risk factors for contact dermatitis include allergies, family history of eczema, regular exposure to a moist environment, burns, exposure to plants, chemicals, and metals, and occupations that require frequent hand washing. That's us. Employment as a computer operator does not increase the risk of developing contact dermatitis, and vital signs are not linked to the development of contact dermatitis. Let me say this right here, y'all. If the person that's a computer operator is coming in contact, because this is where you got to use your critical thinking, because everything ain't gonna always be black and white. So if the person that's working as a computer operator is a germaphobe, and he trying up all these different spray things to try to keep, he just obsessed with germs, would that increase his risk then?
Yes.
Yes.
Why?
Because he's exposing the cleaning products could possibly, wouldn't it possibly irritate his skin?
It would exactly. If he's a germaphobe and saying, look, I got to get these germs out of here. He constantly wiping his phone down, constantly wiping his computer down, constantly wiping his monitor down, his desk, just everything. And he's trying different things that he's read up on Google or whatever the case may be. That increases his risk then because he's bringing the irritant into his environment. Does that make sense?
Yes.
Yes, ma'am.
Okay. All right. Anybody got any questions? I want to make sure y'all got this. Anybody got any questions? Okay. The nurse is planning care for a client with contact dermatitis. Which intervention should be included in this plan of care? Select all that apply. Should I provide instruction on washing clothes and bleach in hot water?
No.
Should I instruct the patient to avoid perfumes and lotions containing alcohol?
Yes.
Should I provide instruction in the use of hot water and soap to bathe the body? Teach the client the need to keep the skin dry, or stress the importance of utilizing prescribed medication for the entire course? So I'm planning care. This is my care plan. What should I include in the care plan?
B, D, and E.
Okay, let's see. B and E. The client should be instructed to use prescribed medications for the entire course. Stopping the treatment too soon could cause rebound dermatitis, which means it could come back and be worse. The client should also be instructed to avoid perfumes and lotions containing alcohol because these will contribute to skin dryness. The client should be instructed to use tepid water, which is not completely hot water. It's kind of like a lukewarm water, and mild soap to bathe. The skin should be kept lubricated to prevent dryness and itching, and clothing should be washed in mild soap and rinsed in extra time to remove all soap. So when we talk about tepid water, lukewarm water, y'all, the reason why we say that is because if they get in hot water, sometimes it can cause people to itch.
I have a question.
Okay, Hannah.
What if they have some sort of like redness, irritation? Like earlier you said something about the skin folds, and you said keep them dry. So what's the difference between that dry? What if it's possibly like a contact dermatitis issue? Do you keep it lubricated then?
But see, the thing about it is the reason why we're keeping the fold dry is because the fold is going to sweat anyway. So you got to keep it dry.
Oh, okay.
You know what I'm saying? That's the point of why you keeping it dry is because it's sweating anyway. So the extra moisture is what yeast loves moisture. So you got to keep it dry or it's not going to heal up. That's why you're going to keep it dry and you're going to put that medication there. That's what's happening there. So those are two totally different things.
Okay, got it.
So the fold is you keeping it dry because it's going to accumulate its own water anyway because it's the skin folded over onto itself. Did I answer your question, Hannah?
Yes, ma'am.
Okay, you sure?
Can I ask one more question?
You sure can. Ask as many as you like.
What if you're talking about between the toes?
Between the toes, you still need to keep that area clean because that's where people get athlete's foot from. Athlete's feet, it's because of the buildup of the moisture. That's where the yeast and candidiasis come from. So it's still, you need to dry in between the toes. And you tell the patient that they need dry in between their toes, because a lot of times if they're using a spray or antifungal, you need to have that area dry before you even spray on the antifungal. Or if they're using a cream or and a lot of times it's a cream that they're putting there, the skin needs to be clean and dry first. Because that's one of the reasons why they have the fungal infection, is because it's moist.
So you wouldn't apply lotion between the toes?
You're gonna put you don't put lotion in between the toes. You put whatever the cream is that they're using to take care of the infection. So let me break this down. You don't tell anybody to put any lotion in between their toes, because the toes are gonna hold moisture there. If there is a medication, let's just say they go and the person prescribes them Lamisil, or the person prescribes them clotrimazole, then they're gonna put a thin layer there, but that's medication, that's not lotion. The medication is what's gonna take the infection away. Hannah.
Yes, ma'am. Got it.
Okay.
Thank you.
I'm saying, does it make sense though?
Yes, ma'am.
So I wouldn't just tell somebody to put Dove lotion up your toes with Dove lotion. I wouldn't just tell them to do that, because what's going to happen is it's going to accumulate moisture while they're walking in their shoes. It's going to accumulate moisture. So even if you are putting lotion on your feet, you need to take the excess lotion from between your toes. If not, you're going to be ashy. Does that make sense?
Yes, ma'am.
Okay. Does that make sense to everybody else? I want to make sure everybody understand though, because that's a good question, Hannah.
Yes, ma'am.
Okay. All right, so y'all, at the end of this, we're gonna go back and do a recap, make sure everybody know what they need to know, make sure we good on all the stuff we need to know. Does anybody have any questions at this point on contact dermatitis and our risk factors and all that kind of good stuff? Everybody where they need to be.
Yes, ma'am.
Okay, so take a look at this picture, y'all. What do y'all notice about this picture?
The redness and the swelling.
Okay, what else?
The line that's drawn to indicate further infection.
Okay, so who said that? Megan?
Me, Jamie.
Jamie, okay, good, Jamie. Okay, so look, it's outline. What is the outline going to tell me? You said to prevent further infection, but what else is it going to tell me? Jamie?
I mean, it'll assess if it spreads any further. If it goes outside of the lines that are already drawn, it indicates the spread of infection, right?
Okay, so let's just say Mr. Calhoun, this is how he looked when he came in. So it's going to let me know two things. This is where it is when Mr. Calhoun is coming in. If I put Mr. Calhoun on some medicine, I should see a what?
Regression. The inflammation should go down.
Exactly. The inflammation should go down, the redness should go down, the swelling should go down, because that's letting me know the medicine is what?
It's working.
It's working. It's effective. But if I get there and this is where it looks like when Mr. Calhoun come in, and then all of a sudden now I notice it's going down his ankle and his heel, what is that telling me, Carmeria?
That is getting worse, the circulation.
Well, it's just showing that the medication's not the medication not doing its job.
Would you do a blood culture to see what type of infection it is, to see what kind of antibiotics would be needed to treat it?
It just depends on if it's weeping or anything like that, if it's draining. Now in this case, then that's just some cellulitis going on. They may use a broad spectrum antibiotic. Now, if you get to the point where this breaks open and starts weeping out, that means it's infected now. So we need to culture that and send it off to see exactly what antibiotic we need to use for that.
Okay.
But Brittany Brown, you said you had a question, Brittany?
No, I was saying we need the extra. the patient questions, like, is he putting it on? Is he using it? And of course, see if it's working or not. I wrote it wrong.
Yeah, because this is where he's in the actual hospital. He could be at home, but we outlining it because we want to make sure this is how it looks in the beginning, and we want to see, like Jamie said, whether it's going to go away or is it going to get worse. And that's going to pretty much let us know whether this patient is either doing what they need to do or whether the antibiotic is doing what it needs to do. Okay. All right, let's move on. We're almost done, y'all. So, any kind of break in the skin, is integrity, swelling, localized redness, or pain dictates cellulitis. So it can be caused by bacterial infection. It could be, based on an extension of a skin wound or ulcer that's traveled up. Any kind of fungal infections or furuncles or carbuncles, and this is just basically boils. So boils can cause this as well. So that's why it's best to kind of get boils taken care of. A lot of times, heat and warm water, a warm compress will take care of it. But if it gets big to where it's causing you pain, you can't walk, you can't do this, then you need to get that looked at. Risk factors: if you're having any kind of venous or any kind of lymphatic compromise, if your blood is not flowing the way it should be, peripheral artery disease, edema, diabetes, all these things are already involved with poor circulation. Skin lesions, if the person is an IV drug user or immunocompromised or suppressed, and any kind of advance in age, because wounds and things don't heal up as we get older. Wounds and things don't heal up as fast as they do when we're younger. Complications: the person can become septic where the bacteria travels into the bloodstream. They can have deep vein thrombosis, lymphangitis where the lymphs are inflamed. It can get so bad, like I said earlier, to where the limb has to be amputated, or you can have a super infection to where they can't find any antibiotics that can heal. And this is all cellulitis. Jillian. So we need to know what their risk factors are. We need to know where they're having their tenderness, where they're having their pain. Have you had any fever? How many days did you have the fever? How high did the fever get? Did you take any medications for the fever? What did it bring it down to? You've had chills. Have you had any fatigue? How many days have you had it? If you look at the actual limb or whatever's being affected, you should see redness. The person should have a complaint of fever. Warmth and tenderness, they don't want you to touch it. It hurts, they'll say it hurts for the sheet to touch it. And they may have some lymph node enlargement because the infection actually drains off into the lymphs. So that's really part of our barriers, your lymph nodes. You should also see an elevated white blood cell count. We'll get a culture and a gram stain of that area, drainage, and we'll send it off to see exactly what's growing there. And then you may get an X-ray to make sure this person doesn't have osteomyelitis. And you can see that on an X-ray. If it travels down into the bone, you should see osteomyelitis on there. You'll be able to see that. And this is destruction of the bone, infection of the bone. And usually with osteomyelitis, y'all, the person has to be on antibiotics for a lengthy amount of time. Why can y'all tell me why would a person have to be on antibiotics for a lengthy amount of time with osteomyelitis, a bone infection? Because what?
It would take a longer time to cure it.
Huh? What were you saying, Dallin?
It would take a longer time to cure it. I mean, it takes a lot for stuff to get to our bones.
Uh-huh. And bone is throughout your what? You got bone everywhere, don't you, Dallin?
Yes.
Uh-huh. And so you want to make sure that you get in there and clear it up. So if you can tell, and I'm hoping that one day y'all will be able to see this, but there is nothing like seeing bone that is infected, osteomyelitis. It breaks off and crumbles up, y'all, just like some crumbs on the floor. You can tell when it's no good. It'll crumble up. You touch it with a curette and it crumbles. And bone shouldn't be like that. Bone should be nice and firm to where you can't just scrape it off. So you can tell when bone is no good because it'll just crumble off. So you want to make sure you elevate the affected extremity. How high do we tell y'all to elevate the affected extremity?
Above the heart
rate.
Okay. You want to use moist heat. You want to do sterile saline dressing changes, and then you want to use any kind of thromboembolism prophylaxis. So let me ask you this: if you got somebody that has cellulitis, do you want to put this person on bed rest?
No.
Okay, good, because you still want the person moving around and letting the blood circulate, right? Right. So you want to make sure the person has a well-balanced diet, and you want to make sure they have the diet that has a good consistency of what? What helps heal up wounds?
Protein and vitamins.
Protein. Make sure they got their vitamins. That's right. Adequate fluid intake, because we don't want anybody to be dehydrated. Activity is tolerated, and then if they got bed rest with severe infection. Let me say this: even with severe infection, from my practice, and I don't know, I'm gonna ask Dr. Mayberry to chime in on this as well. I don't see as much bed rest. Usually, the reason they're on bed rest is because they're in a lot of pain with it. Now, Dr. Mayberry, Doc.
Yes, it depends on the amount of pain and the amount of swelling that the patient may have. Okay. Some of them in a lot of pain that they can't walk.
Okay.
Mm-hmm.
So we echoing each other. Anybody got any questions on that? Thank you, Dr. Mayberry. Anybody got any questions on that? Okay. So you got your mild cases, your severe cases, and your prevention. So this is pretty much how you're going to manage the care with these patients. If you got somebody on a mild case of cellulitis, they'll give you some oral antibiotics, and they may tell you to come back in, and they'll take a look at you and make sure everything is clearing up, make sure you're not having any problems. Did you complete your medications? Did you have any problems with that? If it's a severe case, you may have to be admitted, and they have to put you on some IV antibiotics. And that way they can keep a close eye on it, because we're trying to prevent you from getting septic, and we're trying to prevent the area from getting worse. Okay? And then we just always want to make sure we prevent the patient from having any problems with this later on. Any questions? So nursing diagnosis: acute pain, risk for ineffective peripheral tissue perfusion, impaired physical mobility, and risk for infection. We almost done, y'all. Hang in there. We want to make sure we tell the person, as we just said, about elevation, warm, moist packs, any kind of wound care, and infection control, because we don't want anything spreading. If the person does have MRSA and they're on contact, we don't want them spreading it to their family members. And then we want to talk to them about preventing any further infection. So just a tip for y'all: if it's wet, if it's too wet, it needs to be dried. If it's too dry, it needs to be wet. It needs to have some moisture there, because wounds can't heal up if they don't have the necessary environment to do it. So if the wound is staying wet, we need to dry it out some. And if it's staying dry, we need to moisten it up some. Knowledge check. Which of the following clients would the nurse consider at greatest risk for developing cellulitis?
A.
Let's see. A and B. So the client with PVD, peripheral vascular disease, is at the greatest risk for developing cellulitis and should be taught the warning signs to report to the provider. And then the client with diabetes as well, and that's a part of that person can stem from having peripheral vascular. So the clients with hypertension and muscular dystrophy are at no particular risk. So that doesn't just say just because you have high blood pressure or muscular dystrophy that you're gonna get cellulitis. It's mainly a circulation thing. Which of the following would be the most beneficial nursing action in treating cellulitis? Monitoring the diabetes blood sugar level, encouraging adequate fluid intake, elevation of affected area above the heart, and promoting the performance of frequent hand washing. Let's see. Elevating the affected limb above the heart. Because cellulitis is dependent on an entry point for infection of the dermis, any action that prevents alterations in skin integrity will best prevent cellulitis. It requires a break in the skin for entry by an organism. So blood sugar levels, fluid intake, and frequent hand washing would have an indirect effect on the skin. So tell me and this is what you all gonna post a discussion board, okay? So we're done. This is what you're gonna post a discussion board. I want y'all to tell me, and these are easy questions, y'all. Shouldn't take y'all all night. And I should have changed it, and I'm gonna change it to 5. The discussion board, I want y'all to have it posted by 5 o'clock, not 3. So that'll give y'all a little time to do what you need to do. Tell me what the difference is between contact dermatitis and allergic. What is the treatment for each one? What information is important when educating the patient about each one in prevention, and what are some risk factors? So everything to answer these questions was in this PowerPoint. It shouldn't take you any time to do it. And I'll change that time to 5, and I'll change it in the PowerPoint poster.
Are these questions mentioned in the discussion board? Are they on the before we reply to them? Are they like, or do we need to take a picture of these? And
this is gonna be in the PowerPoint, and I'm gonna post the PowerPoint to online for you.
Okay, thank you.
Yeah, you're welcome. This whole thing is gonna be posted online for you. Only difference, y'all, I want y'all to post it by 5. That'll give y'all enough time to do what you need to do. That better?
Yes, ma'am.
Thank you.
Look, all of y'all came alive when I said that. Okay, do any of y'all have any questions for me?
Yes, I have a question. Okay, so under allergic reactions, under clinical manifestations, it's dry and peeling, and it says ooze.
Go ahead, that Cody?
Yes, ma'am.
Okay, go ahead, Cody. I can hear you. Go ahead.
It says oozing under contact, and it doesn't say oozing under the allergic reaction. Wouldn't an allergic reaction be like poison ivy?
But the allergic reaction, you got to keep in mind, some of the vesicles may not be oozing out. It's just you would have to pay attention to what's causing the problem.
Well, I was thinking
So allergic is just a type of contact dermatitis. It's a type of it.
Okay.
You understand what I'm saying? I want to make sure y'all understand that too. These are just levels of the contact dermatitis. Does that make sense?
Wait, so where does poison ivy fall?
If you look at let's go back. I'm gonna pull it back up for y'all.
Because
it's gonna tell you that the causes could be plants.
Was the allergy one? Because it was associated with plants, right?
Right, and the irritant is gonna be under chemical.
Yes, I think irritant. Isn't irritant the oozing and
Irritant is when you're gonna get around the chemicals, detergent, soap, stuff like that.
And then under allergic, it says the dry and peeling. Well, I was thinking like allergic reaction would be poison ivy, and like a lot of times, like when people get poison ivy, it's like it has oozing.
Not all the time, though, Cody.
Not all the time.
Not all the time.
So that wouldn't be considered a clinical.
Because a lot of times, the patient that I've seen when it's supposed to become an infection is when they start having the oozing and stuff. The patients that I've seen now. So with those patients, it's no longer, the cause was no longer just poison ivy. It had become infected then by the time, I'm saying the ones I've seen.
Is that from like them itching
them scratching and breaking the skin.
Okay.
Because you have to look at it. What causes with poison ivy is the liquid, the drainage from the poison ivy plant is actually what causes the problem. The serum from it. So when you talk about oozing and all that kind of stuff, it's mainly because it's at that point in time, it may be a whole horse of a different color code. It may start becoming more an infection thing by that time. And that's usually what I've seen.
Well, also, some people aren't allergic to poison ivy, right? Like nothing happens when they touch it.
And some people love to have it around their houses. They don't want it removed.
My grandfather can touch it and nothing happens at all.
And he may have built up a resistance to it as well.
Probably.
Oh, Dr. Laws.
Uh-huh.
So like those wipes we use at the hospital, how I tell you put gloves on, is that why? Because it's an irritant?
It could be. The chlorhexidine could irritate other people's hands.
Okay.
Purple Santa cloths are only supposed to be used on surfaces. The yellow tops can be used on skin.
But you know what, let me tell you something. Some people use whatever they can find, they'll wipe their hands off with it.
Me.
Who said me?
Dad.
Whatever they can find, they wipe their hands out with it. And you will see when you, especially now that this coronavirus and stuff is out, y'all, people are taking whatever, and they're wiping their hands out with it. Lysol wipes, whatever the case may be, they're just wiping. They're not only wiping surfaces down, they're using it on their hands.
Spraying
We
down
had a
their
gentleman. We had a gentleman come up to the pharmacy walk up, and we have a bottle of Germex in the drawer because you know they're having to touch the phone and stuff like that and talk to us. But he took Germex and like he wiped it on his face.
Oh wow. Oh wow. What y'all think about that?
That's a little crazy. That's a little too crazy for me.
So is everybody okay with this lecture? Do y'all feel like y'all learned? And I'm going to post this. I'm going to record it and post it to, as soon as I get out with y'all, I'm going to go ahead and post it to the Canvas.
Sounds good.
So that way y'all can review it. Let me stop sharing for a minute so that way I can see y'all face again. Okay, everybody come to life. Come back on so I can see y'all.
I can only come on here for a hot second.
Come to life, y'all. Come to life.
We have the discussion board due by 5, and we also have the post-pneumonia lecture quiz today.
It's and Dr. Mayberry, you can speak to that.
Yes, you have 5 multiple choice questions to answer, due by 5. Hello?
So everybody understand that?
You hear me?
Got it. Yes, ma'am.
Okay.
Does anybody have any questions? I really enjoyed y'all. I hope that the lecture was as close to as it would be if we were in class.
Dr. Laws, I saw Carson trying to get in the video.
Oh my goodness, you should have seen. I've been telling her to move out of the way. You want to say hey? I've been telling her to be quiet and move and everything. Hey, Carson. So if you all have any questions.
Eli over here trying to flirt.
Oh goodness. But if y'all have any questions or any concerns, please don't hesitate to message me or whatever the case may be. Please don't hesitate to do that. So any questions for me? And this is something else I want to make sure that y'all know. I know Dr. Mayberry and I talked about this earlier in the beginning of the semester where we talked about landmarks and stuff like that. That's not information that you need to forget. So I want you to just kind of remember those landmarks. And we talked about gauges of needles. We talked about where you would give medication, who you could give medications to. I want y'all to remember, just kind of go back and brush up on those landmarks. Landmarks that you can use, what kind of needles and gauges and stuff you can use, and what you can use on adults and what you can use on a child.
Like intramuscular injections.
So y'all just kind of brush up on that. So you know, any information that you're giving y'all from the beginning of the semester up until now, you don't need to lose any of that stuff because you're gonna be pulling from it. You're gonna always need it. So you just never know what's gonna be asked. Okay, so just kind of make sure that you just brush over that.
Do we have to post to the discussion board for each lecture, or is it just this lecture? Do we have to post one for oxygenation too?
I know we have to post for mine. You got questions post for mine. You got questions post for Dr. Mayberry. Dr. Mayberry, do you have anything? Does anything else on oxygenation?
No, Dr. PW may have something. You have a routine discussion board that you have to post. To, okay? And you have to make sure you follow the guidelines. You have to post and respond to two peers. Last week, some of y'all did not. So we got to see how we're gonna handle that, okay? You have to make your initial response and post to 2 peers, okay? And since I have the microphone, please go back and check any of your previous work, okay? We cannot grade this week clinical assignments until work have been corrected and resubmitted, okay? You know, so it's a lot, but playing your time wisely, okay?
Cody, our discussion board for Dr. PW is not due till tomorrow.
Okay, well, you're good because she have a class today and tomorrow, and they're closely interrelated, so that's probably why.
I have a question for
on
Dr.
yours,
Laws.
Mayberry, do we have to respond?
Did you get my VCMs, the pre-quiz?
I did.
Okay, I just wanted to make sure it got to you.
Okay, thank you.
No
Dallin,
problem.
who was that had a question? You, Dallin?
Yes.
Okay,
So
what did you
on
say?
yours, do you just want us to make the post and answer the questions? Do we need to respond to anyone?
I just want you to, on mine, just post a response to the questions for me. Just just answer my questions. That's it. And we're gonna go through there and check it. And guess what? I'm not just taking. I know that none of the other instructors are as well. We reading this stuff, because if we have y'all take our time to do it, guess what? We're gonna read it. So don't give us no crap now, because don't think just because this is virtual that we taking anything, because that ain't gonna work. Okay, so when you answer your questions, I want and make sure you put a source down there or something. Let us know you didn't pull this out the sky. We good?
So if our source is your PowerPoint, will we just put at the bottom, we got this from the PowerPoint?
Your source should be your book. Cause all my stuff I got from the book. I'm telling you, when we do this stuff, we have to read this stuff just like y'all do. We have to read it. So guess what? Dr. Law, you got to make sure you validate me. Make sure I'm telling you the right stuff. I could be pulling off Google. You just never know. How you know I'm telling the truth? It's all in the book. That's what I'm saying. If you read your book, this stuff right here, you ought to be sitting back drinking a glass of tea. Okay. Anybody else got any questions for me?
Well, I have a question. I remember the instructions saying that we had to post one reply to a classmate.
That's what I thought.
Yeah, I don't remember, and now I don't see the instructions on Canvas, but I remember it saying we posted our initial reply and you posted to one person.
I think they sent
That is what it said.
for 2 people now. For last time it was 1 person, but I think Ms. Lingle might have sent an update. And so
Okay, I don't remember saying that.
So, okay, it's a learning experience. We'll go with, we're real gracious. We want everybody to be on one accord. So we will look at that, okay? But read it and we'll make sure clarify and we'll go from henceforth, okay?
Okay.
But for today, just answer the questions that I have posted, okay? Anybody got any questions? Anybody else got any questions? Oh, this is another thing, and I think Dr. Mayberry just said it. But please, if we have emailed you back or sent you something back to correct, we need you to get that done as soon as possible. Because guess what? You got CM work coming up for this week, and we can't do our job unless y'all go ahead and correct it. That makes sense?
Dr. Laws?
Who is this? Yes, ma'am. Yes, ma'am, Sam.
I had a question. This is kind of more like clinical specific, but on the summary table, you said we all need help with like APA. What if like we did the APA format that like the book gives us? I just don't know how to cite it otherwise. Like,
so if you look on there, and I'm gonna say this, I noticed, and if this applies to you, then take it. If it doesn't, then scrap it. But on the ones that I saw, it had it like a block format. On there it's supposed to have a spacing there. I didn't see any spacing on a lot of them. It's just like you just typed it out like in a block. And it shouldn't be like that. There's a format for APA. There's a format set up. And if you don't have the book, Sarah, they got it online where you can go online and it shows you how to set it up online. But everything's not set up the same way. You have a way that you're supposed to reference book, a way that you reference magazine, a way that there's different ways that you're supposed to reference this, how you're supposed to give reference to the setup. So the format, when I talk about the format, I'm talking about the way it was set up.
Microsoft Word has a template that you can use that's already set up with APA and MLA, and it also does the references at the bottom.
Okay, so we're not supposed to do it in the table?
Do it in the table, do it in the table, but it's the way you set your reference up. That first block.
Okay.
That first block is what everybody the APA formatting is what everybody had a problem with.
Okay.
So Dallin just said, Dallin, am I pronouncing your name right, Dallin?
Yes.
Okay, great. I finally got it. Okay, Dallin just gave the reference for something he found that sets it up for you. So just try to see if you can get with him and review what that is, because those count for points on your paper. And if y'all don't get the referencing right, it'll count off. And we don't want to take any points from anybody, but if we have to do it, we got to do it.
And y'all are using the most updated form of APA to grade it?
Yes, sir. And when it comes to those magazines, the references for the articles coded, it's not a big difference. As the I don't think when they made the changes, that wasn't one of the areas that was hit with a lot of changes. Anybody else got any questions? Well, I enjoyed y'all and thank y'all so much for hanging in there with me until 12:15, from 10 o'clock to 12:15. Ain't that something? Okay. Well, y'all be good. And if you have any questions or any concerns about anything, just make sure you email me or whatever the case may be. Okay. And if enough people have questions, then we may be able to set up something later on so everybody can do a question and answer if y'all had it. But other than that, stick to the script of this PowerPoint. I think y'all will be fine. Any questions?
Another good news. I'm working on the grades. I will post them later on today.
Oh.
All right.
Deep breathe.
Thank you.
All right. So if y'all don't need anything else, I'll see y'all next time. Y'all be good, okay?
All right.
All right. Take care.
Bye.
Okay. Bye-bye. Okay, so I need to, hold on.